I would like to introduce Dr. Rohit Gudgutia. He is the Medical Director of NOVA IVF Fertility East, a chain of IVF clinics in East India and Bangladesh. And his area of interest are fertility and setting up standards. Welcome, Dr. Rohit Gudgutia. I would like you to take the proceedings ahead. Thank you.
Thank you. Thank you once again, and a warm welcome to all my doctors across India and Bangladesh. A very happy Eid Mubarak to my colleagues as well. Today we come together on the third of our series of NOVA IVF Fertility East Educational Initiative to talk about what is the pet subject for all gynecologists and all budding IVF specialists, that is ovarian stimulation. And to talk about ovarian stimulation today, I will have an August panel. I would say the best panel that we could get together for today's event. And we will go through the next 1.5 hours to try and get this sorted out for most of us to understand how ovarian stimulation works and what are the take-home messages for all of us. As always, I thank people at Bharat Serum and also at Science Integra for allowing us to come together and participate in this knowledge exchange. And I also thank my people at Bharat Serum to allow us to get this going every time. As always, audience is requested to put in their questions. Anything under the sun that pertains to ovarian stimulation is game, and I will have my panel respond to your questions towards the end of our panel discussion. So if you are okay and if the slides are visible to all of you, I'll start out by inviting all my panelists for this ovarian stimulation demystified session. So as is understood, when we talk of controlled ovarian stimulation, we kind of try to look at the vast amount of literature that's available freely on the web. And then we have tried to spin a story around that so that there are some very clear take-home messages for all of us, and that includes us as well. Because ovarian stimulation is something that's always evolving, always finding out new ways to stimulate the ovaries to get a better oocytes, higher pregnancy rates, higher live birth rates. So there's no end to learning as far as ovarian stimulation is concerned. I also would like to put it on table that we are not claiming any originality of thought or process here. All that is being discussed is highly documented and in practice. So this makes sense for the practicing physician because we talk what is being done and not what may be done in future. And of course, as we mentioned, we meet at the behest of Bharat Serums and vaccines. So what is the aim of ovarian stimulation? To keep it short and simple, it has to be simple. Like anybody, anywhere with minimum of learning curves should be able to stimulate the patients. It should be soft, meaning there should not be too much of side effects like hyperstimulation. It should be safe. It should be comfortable to the patient. And eventually it should lead to a successful outcome. Most important in Indian and in Bangladesh context, it has to be affordable and accessible. Today, when we meet in 2020, we talk of birth of a healthy singleton term baby as the goal of infertility management. Gone are the days when we were proud of our twins and triplets. So, in a summary sort of a way, what we have to aim for is minimum or no complications and maximum success. Today's panel discussion, and I'm sure my panelists will also vouch for it, we will be talking about what is safe and what is reasonably successful. The house today is an August house. To introduce the house, the doctors, it's my proud privilege to call upon Dr. Oindri Sanyal, significant member of the NOVA team, clinical director for the Kolkata Center, and a vast experience of more than 5,000, 6,000 IVF cycles under her belt. Welcome, Dr. Oindri Sanyal, to this panel.
Yeah, good evening.
Nivedita Mishra, she's our doctor colleague at Ranchi. She brings in her fresh air of learning recently, and she's joined our team recently. So we welcome Dr. Nivedita as well from Ranchi.
Good evening, everyone.
Welcome, Dr. Nivedita. Dr. Pragya comes from Patna. She has been practicing IVF independently for the last couple of years, very successfully. And it'll be a pleasure to hear Dr. Pragya's opinion and views on various aspects of ovarian stimulation. Welcome, Dr. Pragya. And Dr. Pragya, you'll have to switch on your mic, please.
Thank you,
And
sir.
most welcome. And finally, the guest on today's show is Dr. Shagorika Basu, independent IVF consultant, and again, wealth of experience supporting her, and a very good friend of all of us at the panel. Dr. Shagorika Basu, welcome again. Dr. Basu.
Hello and good evening to everybody.
Yeah, hi, thank you.
Hi.
So I'll start the ball rolling. I'll ask with the youngest member in this panel, Dr. Pragya, to help us understand what's the difference between ovulation induction, superovulation, and controlled ovarian stimulation. We tend to use these terms as kind of alternates for each other, but do we see a difference, a subtle difference between these three terms? What is ovulation induction? Who do we do it for? What is superovulation? And what is controlled ovarian stimulation?
Yeah. Here in the ovulation induction, our idea is to achieve monofollicular growth and ovulation, especially done in case of anovulatory patients, and it is done for timed intercourse or insemination.
So
In
basically,
superovulation,
that's
yes.
for natural conception mostly, and we are looking at women who do not ovulate themselves and they need support from us. So that's what
Yes.
ovulation induction is. The aim is a single follicle. Superovulation, madam?
Superovulation, we try to achieve multiple follicles, and in control ovarian stimulation, the same, we try to achieve here also the multiple follicles, but the idea here is to control the ovulation by preventing the endogenous LH surge with the help of GnRH analogs, either we use agonist or antagonist.
Thank you. So that's a clarity that's usually not there. Superovulation is something that we use for IUI protocols where the number of follicles may be more than one, but the ovulation is largely not controlled by us. It will ovulate spontaneously if it wants to. But in controlled ovarian stimulation, we also aim for multiple follicles, but here the ovulation is also controlled with the help of an agonist or an antagonist. Thank you for clarifying. For today's purposes, however, when we are talking about ovarian stimulation, we are only talking about controlled ovarian stimulation because we are not going to talk about timed intercourse insemination. We covered that in our first session. All of you who participated must have been privileged to hear that. And today we'll be talking mostly about ART IVF because ESHRE has decided to use controlled ovarian stimulation to confine to ovarian stimulation for essentially for IVF and ICSI. So these are the various protocols which are in practice today. There is the standard long mid-luteal protocol, also known as the agonist protocol, and the standard short antagonist protocol. These are the commonest used protocols. And then you have the ultra short, the short, the stop and the start, the sandwich, and so many other protocols that are in vogue. What's new in COS? This text, this guideline by ESHRE is new, came out last year and is a very comprehensive review of the stimulation protocols, the ifs and the whens and the buts. And anybody who's interested in ovarian stimulation should find time to go through this document. It's around, it's freely available, open access document. What are important and what's accepted in COS today is basically first we look at the patient and try and identify the kind of patient that she is. Then we try and identify the treatment that we want to do for her and individualize the COS treatment for her so that we have a synchronous cohort of mature oocytes. We, of course, look at prevention of potential complications. And if possible, in today's scenario, we preserve the surplus embryos so that we need not stimulate her once again in case she fails or she's looking for a second child. So this is something that's largely accepted, the non-controversial part. And of course, to repeat, safety and efficacy is the most important aspect of ART management today. What's debatable, and that's why we are here. What's debatable is what is the right number of eggs? How do we call this a good stimulation? Do we want to treat our patients? So many questions are there. What's the kind of right protocol? Every time you go in the conference or a meeting, the same questions are asked, but nobody really knows the right answer. Do we add something extra for my eggs to become better? When do you start luteal support? What is the dose? Till when do you continue? How long do you continue? So on and so forth. These are questions for which we actually do not have the right answer or the proper answer. To set the ball rolling, we'll have the first question that rolls out for the ovarian stimulation part for Dr. Shagorika Basu. What is her experience? And again, as we've done the rest of the panel discussions, is we'll ask you specifically about your experience and we'll not talk about evidence or literature much. So my first question to Shagorika Basu, Dr. Basu, is what in her view is the right stimulation? How many eggs is she aiming at when she starts stimulating a patient?
Thank you, Dr. Gudgutia. I think if I am able to give this answer, a lot of our confusion will be cleared. And I don't think that we have been able to find that magic number yet. So the ideal number of oocytes, if we take it, I don't think there is any ideal number as such. So what we are aiming, as you rightly said, that safety and a good success. So we should be stimulating our women, controlled ovarian stimulation, so that we get an adequate number, as we cannot, we do not have to classify them as poor responders, and at the same time we get a number which do not indicate that they have hyper responded. So something in between. And what is that number? So if I have to quote, or if I have to go through so many studies and literature, if I have to really quote a number, I think anything between 6 and 15 is probably something we are looking at. And there has been several classifications, groups, women have been grouped, having eggs between 6 and 10, between 11 and 15, probably they are ideal. Anything more than 15 indicate hyper responders. Anything less than 3 or 4 are poor responders. So if that's how my experience have been.
I'll take this question to Dr. Vahendri. Amongst the group that practices at Nova Fertility, Dr. Vahendri is considered as the master of stimulation. So or rather the mistress of stimulation. The question to her is, when she takes up a patient for an IVF cycle, looking at her ovaries, she may be a hyper responder or a normal responder or a poor responder. I'd like her to comment on what is a hyper responder as well on this while she talks about this, who is a hyper responder or who is a poor responder. But primarily, when she looks at a patient, what is the optimum number of eggs that's in her mind that this patient should give me these many mature oocytes for me to be happy with her stimulation?
Yeah. Dr. Rohit, I think at the outset, I would just like to clarify something. Previously, there were days when we were talking about mild stimulation. Mild stimulation is something where we used to give less medicines to a patient, used to aim towards getting less eggs from the patient. But obviously, there have been a lot of literature regarding mild stimulation. But as of now, the consensus that has emerged from ISRA is that the ideal way to go about with stimulation would be a conventional stimulation, meaning something between a gonadotropin dose of 150 to 225 on an average. So
I'd interrupt here. This is an important, I think, a message to all of us here, that while we talked about the mild stimulation being a more natural form of stimulation, as evidences come by and experience also comes in, it seems that maybe the outcomes are best achieved with what she says, a conventional form of stimulation, rather than experimenting with mild stimulation. This is what Dr. Vahendri is pointing out, which I think is a very fair observation. Please go on, doctor.
So when we are stimulating a patient with conventional stimulation, see, we are talking about the ideal scenario here. Our ideal scenario would be to produce on an average something between 15 to 20 oocytes or follicles, so that probably we get more euploid blastocysts out of that patient. So
if you look at, again, I'm interrupting you. If you look at number of blastocysts, what would be your take home, like a good cycle, one for fresh and one for frozen? Is that what you look at it? What's the kind of number of blastocysts that you aim for?
See, ideally for a pregnancy, we need one single euploid blastocyst, obviously. But since we cannot always be sure whether that particular blastocyst is an euploid one or not, obviously it makes sense to have 2 or 3 in hand.
So you would be happy if you had 3 blastocysts per stimulated cycle?
Yeah, surely.
So that's again a very good take-home message. In 2020, in today's scenario, with the labs that they are in today's scenario, a number of 3 blastocysts is a reasonable assurance of a pregnancy happening to that person, something around 80-90% chance that she'll go back with a pregnancy with this cycle. So that's another way of looking at a good stimulated cycle. Thank you, doctor. Please go on.
One more thing I would like to add, that studies have shown that each single egg makes a difference towards a pregnancy. So, now, like in difference to what we were preaching a few years earlier, in contrast to mild stimulation, now the dictum is the more the merrier.
So that's the controversy that we talked about. So while there was a celebrated paper around 10 odd years back, which talked about the magic number of 6 to 15 oocytes and a pregnancy rates thereabouts of 35 odd %, which was based on a large number of patients, cycles of around 400,000 cycles were analyzed. The subsequent evidence or the subsequent wisdom that's come around is that maybe more number of eggs do not always mean a bad outcome. In fact, if you have more than 15 oocytes, the cumulative pregnancy rate is close to 60-61%. This is what this paper brings out, provided you use the surplus embryos for subsequent transfers. So that's also a...
I would just like to interrupt at this point.
Please.
In our initial days of stimulation, there was a misconception that if we are producing more eggs, the aneuploidy increases. But recent papers are clearly showing that even if you are producing more eggs, then the rate of aneuploidy is not increasing among the eggs. So that is also a myth.
So that's another very, very valuable takeaway. Thank you, Dr. Vendri. That higher number of eggs need not always mean poorer quality eggs. That was something that we have carried on with us in the last couple of decades of practice. It may be that in some subset of patients that may be a reality, but by and large, that's not a fact and that's a myth, as Dr. Vendri points out. I think these were 3 very, very important takeaways that came out from her deliberation on this topic. Before I'll stick to Dr. Vendri here. Before she takes up a patient for an IVF cycle, what is it that she is looking at in terms of patient classification as regarding to what is the optimum response that she might get from this patient? What does she check for? Is it the AMH or the AFC? What is it how does she select her patients, if she can elaborate?
See, very frankly, for somebody who is doing the scan himself, AFC is good enough. But for sometimes for patient comfort or to convince the patient, we have to do an AMH. In ideal scenario, the AFC and AMH should corroborate, but there are instances where they do not. And if they do not, I will go with the AFC.
So she trusts AFC more than the AMH because there are lab issues and other issues with the AMH blood test as such even now. Please go on, doctor.
And basically, when we are starting the stimulation, we would probably classify the patients into 3 categories as such. One would be an expected poor responder, one would be an expected normoresponder, and one would be an expected hyper responder. An expected poor responder would be some patient who is probably elderly or has a low ovarian reserve even at a young age. So they would be on an average expected to produce less than 10 eggs, probably something between 1 to 3 or 4 to 9, something like that. Then there would be something called normoresponders who would be on an average expected to produce around 10 to 15 eggs. And finally, we would have the hyper responders who would be on an average producing more than 20 eggs. So these would accordingly, at the outset, after I classify the patients, my stimulation protocol will basically depend on how I classify my patient.
Absolutely, absolutely. So this is the kind of stratification of patient that she carries out for all her patients. Are you still using FSH, a basal FSH on day 2, day 3 that we used to do a couple of years back, or have you stopped?
No.
Oh, so she stopped.
No, completely stopped.
Fair enough.
Not using.
So we have discontinued with the practice of checking the FSH levels. AMH, because counseling is a lot dependent on the AMH values. So we do the AMH, but for our own satisfaction and for prediction, we trust most on antral follicle count done ourselves in our machines, and therefore then planning the dose, etc. for the patient. I would also like to point out here that these are things that we can get from the patient even before we start the cycle. Her age, her previous response to an IVF cycle, her AMH value, as we understand that it may not be very reliable, but even then that's a good indicator. The AFC. Genetics of the patient is also becoming relevant, but that's mostly a post-facto diagnosis. In case a response is not to our liking, the day before yesterday we were discussing with Dr. Pragya about one of our patients where the response was not as per her expected lines. So Dr. Nivedita, would you explain how genetics also plays a role in selection of patients or response of the patients? Dr.
Yeah, am I audible, sir?
Yes, please go ahead.
Okay. Yeah, the genetics has come recently across. We have studied these topics, but because the response, that hypo response that we are getting, that is the asynchrony in the number of antral follicles we see and the pre-ovulatory follicles we get. Because of the asynchronous relation between the two, that when we are seeing that there are a large number of antral follicles and the number we are getting pre-ovulatory are less. So FSH receptor polymorphism has come into the picture that maybe some of the follicles are sensitive, not sensitive enough to the FSH because of the receptor polymorphism. Another factor that has come in PCO is because of the LH receptor polymorphism. The genetic play a role, and there is higher LH level in them. And these, though it is difficult to study or to elicit who will have this polymorphism or the altered response, but yes, that has come into the play, and we have to keep in the mind the genetic factor when patient is giving a hypo response.
So what she means to say, of course, is that that's again a very important point, that when a patient is recruited for an IVF cycle, we decide on the dose based on her AMH and antral follicle count. But sometimes the response is not good in the sense that we do not have enough mature eggs coming out of her ovaries as we'd expected. Two of the reasons for that could be she could have FSH receptor polymorphism. So there could be a genetic mutation in her FSH receptor or in her LH receptor, which as yet is not being checked routinely in any of the IVF labs. So when we have an unexpected response, what is known as an unexpected poor responder, that may explain why this has happened. And we should not start thinking too much about our inefficiencies. So this is one area that needs to be understood and learnt in details as time goes by, and I'm sure sometime later tests would be available for us to be able to check before we start the cycle whether that person is carrying any kind of a receptor polymorphism. A very, very important points that we're being pointed out. Dr. Pragya, I'll come to you, and I'll also want Dr. Shagorika to participate in this, is that once we have kind of looked at our AMH, AFCs, and then we want to start a cycle, what's your go-to protocol? Do you put them on oral contraceptive pills or estrogen or progesterone before you start the cycle so as to batch the patient or time her pickup, or do you go on a spontaneous start cycle? I would like all four of you to comment on this. Dr. Pragya.
Earlier, when I used to do batches for the IVF cycles, I always prefer the OC pills for scheduling purpose. For about 12 to 28 days we can give from day to day 5 of the menstrual cycle, and after 5 days washout period we can start the stimulation.
So again I'll interrupt here. Now that you're not using pills, do you see any difference in the stimulation? Because many people say that with pills the response is slower, requires more gonadotropins. In your life, in your practice, have you seen any visible difference?
No.
So if you put your patients on low dose pills for a limited number of days, then most probably there is very subtle difference that does not come out that often in stimulation. Dr. Vaindri does not use pills. What about Dr. Vaindri's opinion and Shagorika's opinion, please? Dr. Shagorika, will you start?
I would probably comment like Dr. Pragya. I'll go on an opposite direction. I would say that when I used to work in the infertility unit in Glasgow, pre-treatment with OC pills was not a common practice. So there were many reasons for it, because over there it worked as a unit, so it was a 7-day available service. So there was not much role of planning as such the workload, apart from only bits and pieces. So we could actually follow the cycle and then start the stimulation as you would plan, either like agonist or antagonist accordingly. But after shifting here, what I have seen that yes, because here the structure of practice is a little bit different. I have noticed that it is
more
easier
individual
for,
oriented.
yes, it is easier for both the doctor and the patient if we can have a little bit of pre-planning. So I have started using, I have started pre-treating some of them. Not, I would not say I have completely switched over, but I have started pre-treating them with OC pills, as you said, low dose, like 12 to 16 days of use, and then plan it accordingly.
So
Again, I have not noticed much difference in
absolutely.
the outcome really.
So because your experience matters a lot to our audience, you say that you don't see much of a difference between pre-treated and non-treated patients. Dr. Vendri, will you agree, differ? What's your opinion?
Actually, frankly speaking, I have only used pills in my practice before. And after having used pills, I definitely have noticed a blunted response. And after that, I don't use anything whatsoever prior to IVF. And this is due to so many reasons, including logistic reasons, because the patient would just turn up on the cycle day 2 or 3 for an IVF. And at that time, there is no time for pre-treatment also. But after going through the literature, I was surprised to see that what I have been doing, in fact, not giving any pre-treatment at all, whether estrogen, whether progesterone, whether OCP, or whether antagonist. What I found is that is in fact evidence-based. So I was quite happy with, I am quite happy with what I am doing. I don't give any pre-treatment at all.
And you think that your outcome is now better without any pre-treatment as opposed to when you used to use pills for your patients?
Yeah, as I told you, I have only used pills in my practice before, and pills definitely lead to a blunting of response.
Okay, so this is interesting. So we have two people who have not seen much of a difference, but one person feels that there was a blunting of response. This is what it is. Variety is the spice of life, and that's how things come out. Dr. Nivedita, have you used other agents like progesterone and estrogen to time your patients so that you can have a very relaxed life, as Dr. Shagorika was pointing out?
Yes, sir. Estrogen I have used because I find that pills that were used in donor programs, the response was blunted. This was my finding also. I found that the number of, though the donor is having good number of eggs, but the M2 received very much less. It might be because the agonist trigger that we give them, because of much suppression, LH activity might be less. These might be the reasons. Okay, so that's why previously we were using like pills for not more than 10 days. But now, after using estradiol valerate, of course, it can be more timed because estradiol valerate can be extended up to for 5 days. Usually we give, but it can be extended up to 3-4 days more, and then from the next day it can be started. The cycle can be started.
So that's another view that is very welcome. So we have two on the panel which says that pills make a difference, and two on the panel which say no, they don't make a difference. And then we have Dr. Nivedita coming back and telling us that instead of pills, she's now using estradiol valerate for scheduling of cycles. So like each one to his own, everyone chooses the way he wants to go. And mostly the opinion is divided all across the world. I show you this evidence from the ESHRE guideline that we talked about, which says that the guideline group acknowledges that estrogen and progesterone are widely used for scheduling purposes. This is possibly or probably acceptable given the data on efficacy and safety. So they have also kind of sidestepped whether yes or no. They have also said, yes, it is in practice, and let it be in practice. We are okay with that. So that's what makes ovarian stimulation so interesting and so nice to know all the time. There is some clarity, however, which is coming about the choice of the GnRH analogs. We were largely an agonist-driven practice, and now we have largely moved into antagonist-driven practice. There are some solid reasons behind it. There are still supporters of the long protocol, the agonist protocol, but by and large, the practice has shifted to the antagonist. Dr. Shagorika, what's your poison? Which is the way you want to take your patients, and why?
Antagonist cycles are becoming more and more popular, and the main reason for this is the reduced chances, or maybe shall we say no risk of OHSS. So
the antagonist cycle with the agonist trigger makes life very easy for the clinician because the risk of hyperstimulation is almost nil. Yes.
Yeah. So again, I have practiced both long protocol with GnRH agonist and antagonist, currently coming more into my practice. I would say that for poor responders, again, in my previous place of practice, we used to focus more on the long protocols for the poor responders, but for the predicted hyper responders, or maybe some for predicted normal responders, antagonists were the choice.
Okay, so you're still sticking to that
I would say I have started shifting again. I mean, because it is a complete change of my practice now. So I have started developing some new or maybe incorporating some new practices nowadays. So here I am mostly inclined to antagonists, I must say.
So I'll just come back to Dr. Oendri on this. Before that, I'd like to show this evidence again, is that they've looked at the antagonist versus the agonist, and this is again very celebrated. We've seen this many times in conferences. There seems to be absolutely no difference in using urinary versus recombinants. Similarly, there seems to be no difference in using antagonist versus agonist. But I would agree with Dr. Shagorika that what tilted the favor, things in the antagonist favor, was the fact that with an antagonist you could combine an agonist trigger and therefore stay away from hyperstimulation completely, thereby ensuring that the cycle is safe for the patient. So that's where in the last 5-6 years, the shift has happened towards the antagonist, mostly cycles. Dr. Oendri, your comments on this, please.
Yeah, I would agree on that. Between an antagonist and agonist cycle, it is about equal efficacy and more safety in the antagonist cycle, because we are always debating efficacy versus safety.
Absolutely.
So obviously we would go with something which is equally efficacious but more safe.
Absolutely. So I'll like to close this section here, that by and large the House is in agreement that the antagonist protocol is the protocol of choice across all sections, whether it's a hyper responder or a normal responder or poor responder. Of course, we could have our own personal issues and choices, but by and large we've started using antagonists as the go-to protocol. There is something that we have heard of recently, and that's a hypo responder. This was briefly mentioned by Dr. Nivedita in her introduction to genetics. But we know that before we start, we are expecting her to give us many eggs, as Dr. Oendri pointed out, or a normal number of eggs, which is around 15 eggs, as Dr. Shagorika pointed out, or maybe she's not going to give us that many eggs. But what is a hyporesponder? And what is the knowledge that we have right now about hyporesponders? That's something that we will discover in our panel discussion sometime later. Another point that is of debate is the use of LH. So I had asked this question to the panel before we started as to your views on LH addition in an IVF cycle, or do you think that it makes no sense to add LH, recombinant LH in an IVF cycle? I'll start with Dr. Nivedita and then we'll take everyone's opinion. Do you think that giving LH in addition to the FSH stimulation makes a qualitative difference to the oocytes?
Yes, sir. LH may be needed in the cases who are group 1, WHO group 1, such as hypo patients. The recombinant LH may work. And in the poor responders also. But the reason is that apart from recombinant LH, we can have the HCG driven LH, that is an HMG, that is more effective, that and more we have been using also, that is HMG, I find more effective than LH itself.
So you would like the LH activity to come in, but instead of the expensive recombinant LH, you are happy to use an HCG-driven LH activity.
And because HCG is having a longer half-life, and that is also an important point than recombinant LH that I find.
I think that's a very fair call. Dr. Shagorika, Dr. Pragya, Dr. Oendri, would you like to add to this?
Yeah,
who's your
Yeah, please. Like to add something.
Yeah,
in this context, I think what Dr. Nivedita has already said, I think I would almost 50% agree with that. Obviously, the indicated uses of LH would be hypo, and poor, and an expected poor responder. But in this context, I think we should discuss something what is called a hypo responder. Somebody with a normal ovarian reserve but with a poor response. Either a young patient or an old patient, Poseidon 1 or Poseidon 2. So in those patients with an unexpected poor response, in spite of having a normal ovarian reserve, if the patient behaves like that in one cycle, in the next cycle, we can definitely consider adding LH to that particular patient. So and definitely, Dr. Nivedita mentioned, HMG is definitely a surrogate LH.
These are again pearls of wisdom coming in from Dr. Vendri. We will be covering all this in a subsequent section, but what she is doing is a wonderful introduction to the fact that there are hyporesponders or unexpected poor responders, and to manage them, maybe this becomes a useful tool. Dr. Pragya, your opinion, please. Whether you like to use HMG or because of the LH activity, or are you a FSH person, do you see that it makes any difference if you add HMG to your IVF cycles?
Yes, I actually go for HMG because it is cost effective also, and
Okay.
in not all patients, in some group of patients like Dr. Henry ma'am has said, in poor responders or hypo responders, and also in the older age group, I would like to add the either a recombinant FSH and LH or HMG from day one of the stimulation.
I'll just ask your personal experience. Have you seen any difference in terms of outcomes, both in terms of egg quality and blast formation, and then subsequently the pregnancy rates?
Yes, definitely. When in case of hyporesponder patients, when I add the LH HMG from day 6 or day 7, I have added it. Definitely, I actually get the better results.
Okay, fair enough. Dr. Shagorika, I'll give you the final word on this. What is your usage of LH or LH surrogate in a stimulation cycle?
I would agree with the rest of the panel that recombinant LH is not a routine practice in our COS protocols. But again, in my practice, I have from my experience, I have seen that hyporesponders, particularly for the patients who had unexpected poor response in a previous COS cycle, adding a small dose of recombinant LH to recombinant or to the conventional dose of recombinant FSH has been done in my previous unit in Glasgow, where we used to add 75 international unit of recombinant LH right from the start of stimulation.
That's another point. That's another point. Many units you like to start right from day one and not from day 6 or day 7, which has been the conventional wisdom. So these are again nuggets of information that come in whenever we sit down to discuss all these issues. Please go on, doctor.
And that has definitely shown some response compared to not using recombinant LH. But at the same time, I would agree with the point that HMG as well can very well act as a surrogate LH.
And you're comfortable using HMG for your stimulation protocols, which is again very fair. Before we really go into the please.
Actually, thing is, in the context of giving LH to hyporesponders, the problem is this is always a retrospective diagnosis.
It's always a second diagnosis. Absolutely.
That is the problem, because if the patient behaves like this in a particular cycle, only in the next cycle we can consider adding LH or HMG to that particular patient. And obviously, in the Indian context, we may not always have patients willing to repeat cycles. That is a problem.
So this is a wisdom by hindsight. This is a wisdom by hindsight, and as she pointed out, the patients don't give us the benefit of coming back for a second cycle, and that's something that we need to impress on our patients, even when the cycles are during the cycles that we are not really getting the optimum response, and this is something that we would like to do in the second cycle. Dr. Shagorika,
I did controlled ovarian stimulation in a young patient. Patient would be between 25 to 30. IVF was being done for male factor. And we had almost 15 to 20 follicles, out of which we got only 6 eggs. So, and ultimately the patient did not conceive, obviously, and the patient hasn't come back to me. But on hindsight, I'm thinking that probably, I don't know, I have been thinking why it happened, because I really could not detect any female factor of infertility. So that is what I am thinking, that after producing 15 to 20 follicles, why the follicle-oocyte ratio would be so bad in such a young patient, when I couldn't detect anything obvious. So probably in this patient, probably in a second cycle, if I could have added LH or used HMG, probably her response might improve. I don't know, but provided the patient has to come back to me.
Absolutely. So this is the hard reality of practice that we carry out in our country, where our colleague doctors who work with us in such close association, they also have a role to play. When the cycles do not do well, and sometimes they do not do well because of the stimulation issues, which we also cannot predict. Then when the patient goes back to their primary physicians, then they can be educated about these things, and which is why these educational initiatives do make a lot of difference. Dr. Shagorika, you were saying something and I interrupted you.
Yeah, no, absolutely. I do agree with Indri, and as I said at the start of this discussion, that these patients where we used recombinant LH were always, they always had a cycle before. They were never, that was never the first IVF stimulation at all.
Absolutely.
And in the scenario of Indian practice, I would again agree that getting the patient back for second stimulation cycle is difficult, and that too if we then recommend a recombinant LH, which may add to the cost of it,
yes.
that is again very difficult to convince.
Thank you all the doctors for such honest opinions. I'll come to the sections of hyperresponders and we'll take them very fast, because then we really want to go to the really controversial areas. Dr. Pragya, if you see a predicted hyperresponder, do you still stick to your standard dose, or do you lower your dose because you don't want to have too many follicles growing altogether? What's your practice?
In hyperresponder cases, actually I decide the dose according to the BMI of the patient. If it is normal BMI, I go for 225 to 300 in IU, HMG or recombinant FSH. And if the patient is thin or a PCO patient, then I can go up to lower down the dose till 150 IU also.
Okay, so I think yours is a slightly more aggressive kind of an approach. And what about using FSH versus HMG? You are comfortable using both, even in a hyperresponder?
Mostly I use HMG here because of the cost. But in hyperresponder, it is better if we give the recombinant FSH.
Okay, so these
patients are mainly PCO patients.
So that's one controversial area. In the last, I think 5-6 years, people have talked about high progesterone values during the stimulation cycle, especially if it's a hyperresponder and if she's been stimulated with recombinant FSH. So there is this evidence, or this I think paper, they have done some very hard mathematical calculations where they have said that the LH-FSH ratio has to be a close approximation of 1:2 for the progesterone rise to have least effect in a stimulation cycle. Or in other words, they're trying to say that there is a ratio that's predefined in the body. If the LH levels are lower than that ratio, then there is a high tendency to have higher rise of progesterone even while the stimulation is going on, leading to bad oocytes. I would come to Dr. Vaindri and Dr. Shagorika on this. Have you had any sense of high progesterone during a stimulation cycle? Do you think that affects your oocyte quality? It definitely makes impression on the endometrial receptivity, but what about the oocyte quality? How do you tackle this? Any opinions on this? Dr. Vaindri, will you start?
I would just like to say at this point, see, my cycles are almost without hormone assessments. I do a progesterone only if I am planning for a fresh transfer. Otherwise, for frozen embryo transfers, I do not do a progesterone. So only with fresh transfers, just prior to giving the trigger, if I notice that the progesterone level is on the higher side, only then probably I would consider not doing a fresh transfer for that patient. Otherwise, I do not do a progesterone estimation at all.
So that's also another view that we get, that she does not use hormones to assess the stimulation quality. She uses only when she is planning an embryo transfer. So you're not looking at the estradiol values per follicle or the progesterone levels per follicle to kind of decide whether the stimulation is going in the right direction. Right, no, Dr. Vaindri?
I go only with the ultrasound.
Fair enough. Dr. Shagorika, your opinion, please.
I would say that I am still in the old school. I do monitor the E2 level, but not P4 regularly. P4 I tend to check only before or on the day of trigger, that time. But again, ultrasound or folliculometry is the mainstay of monitoring, I would say. But I like to see that my estrogen level is going up as I expect. I like to see that.
So that's more for reassurance rather than for change of.
Yes, absolutely. Absolutely.
That's very, very, very fair and very practical, that we use estrogen once in a while to be sure that we are going in the right direction, not for the change of protocol or increasing the dose.
Absolutely.
In fact, nowadays we don't do much changes
No.
in the protocol during the stimulation.
Sure.
That's what the standard practice has become. Dr. Nivedita, the bulk of your patients are either poor responders or hyper responders. Very few of your patients are actually normal responders. So if you do get a normal responder patient, maybe for a male factor or for a tubal disease, what is your standard IVF stimulation protocol?
So the standard is always the 150 to 225 FSH, recombinant FSH is preferred in, and HMG also I'm using quite frequently. That is 150. HMG is quite, and that is the.
There's some people, I'll interrupt. There are some people who seem to say that the FSH versus HMG efficiency is not the same. So if you're using 150 FSH, you should use 225 HMG. Would you agree with that, or do you think that no, both work equally well?
I have not seen any difference till now. I find both equally well. That is the thing with the HMG.
I'm sure you must be using Bharat Serum HMG for your stimulation protocols.
I think that would be a reflection on the company, not on the molecule.
That's true. That's true. Absolutely. So, okay. So that's your standard protocol. And then you use an antagonist, and then you trigger with
the
HC.
preferred trigger is always antagonist. If I get a good follicles, is a preferred trigger is antagonist. And preferred trigger is agonist.
Agonist. Okay. So I think that's become the standard stimulation protocol all across, that we select our patients, put them either on 150 or 225, or in some high BMI patients, put them on 300, stimulate, put them on antagonist. Is it an antagonist from day 5 or after the follicle has reached 14 millimeters? It's a fixed or a flexible dose?
It's a flexible one when it becomes 14 mm.
Okay.
When the lead follicle is 14 mm.
So you trust your own instincts, you call them for a scan, and once the leading follicle is 14 millimeter, then you put them on the antagonist. And in most cases, to be on the safe side, you trigger with an agonist. So that's I would say that's pretty much the standard all across nowadays. Have you looked at something different for the low responders, Dr. Rohindri?
Pardon me?
Have you looked at doing something else for the low responders?
The screen actually.
Okay, so the question is, are you doing something new or something out of the way for low responders?
In what sense?
Is it an antagonist cycle? Is it an agonist cycle? Do you see any difference?
See, nowadays for poor responders, the new concept which has come is using agonist cycle instead of antagonist cycle. So that is a new thing actually, but very frankly, I usually go with antagonist cycle even in poor responders also. Okay,
so that's your preferred protocol. And what about the FSH HMG dose? Do you think that increasing of the dose beyond 300, I've seen you in practice and I hardly ever see you using more than 225, but have you seen or have you felt that increasing the dose would be more helpful in these patients?
No, not more than 300.
Not more than 300. Dr. Shagurika, any opinion on this, or you think?
Not more than 300. Although I have seen in previous place of practice going up to 450, but I don't really think that pushing it too high makes much of a difference.
Dr. Pragya, what is your opinion about the increase of FSH till the time that you are saturating her with FSH given from outside?
Yeah, I actually always start from 225 or 300. But when I see a scan on day 5 or day 6, if I am getting the follicles of lesser size, sometimes I increase dose to 375 international unit.
Okay, so there is a change of dosing in midway if you're not happy with the response.
Yeah.
Nivedita, are you sticking to 300 or is it 450 for some patients?
No, so the ceiling is 300, and if in the poor responders, if the ovarian reserve is less, like if AFC is less, then even the lesser dose like 225 is better, because you cannot push more follicles by increasing the dose. That is the view I have.
So this is a very sensible point actually. If there are no follicles, then just by giving extra dose will not actually produce new follicles. So there's no point in standard dosing the patient 300 IU. If you give higher dose, that does not necessarily translate into more eggs or better eggs. That's again a consensus that we are able to get out of everyone. again, we've done all these normal responders, lower responders patients. We'll have to now come to a new area of discussion, and that's the Poseidon criteria. Before we really go into details of the Poseidon criteria and specifically about the hyporesponders that has been mentioned by all of my panelists, Dr. Pragya, will you do the honors of introducing what is a Poseidon criteria?
Actually, the Poseidon group has shifted the terminology, which we earlier used poor ovarian response. They have shifted the term to low prognosis patient or hyperresponders. And they have classified these patients into 4 groups based on their ovarian reserves, and also and they have included the age criteria also. They have classified into 4 groups, group 1, 2, 3 and 4. Group 1 and group 2 are the patients with adequate ovarian reserve. But
so the ovarian reserve is good.
Good. But with the unexpected poor response or suboptimal response, their AFC is more than equal to 5 and AMH more than equal to 1.2 nanogram ml. And group 1 consists of young patients less than 35 years, and group 2 consists of older patients more than or equal to 35 years.
So
and
group 1
3,
and 2 are basically people with good reserve, still poor response.
Yeah.
And group 3 and 4 are people with poor reserve, therefore a poor response.
Expected poor response.
Yeah,
yes.
so that's the basic classification. And how does this help you in your practice? It definitely helps you to counsel the patient, put her in a realistic path of success rate, tell her that these are her chances.
Yes.
That's definitely one. Other than that, how does it help in your practice? We've talked about hyporesponders. We've talked about other things, use of LH in certain patients. How do you think that classifying patients in the new criteria is helping you?
Actually, it helps to personalize the treatment for individual patient. Whether I will go for the antagonist protocol or agonist protocol, whether there is any polymorphism of FSH receptor or LH receptor, what should be the starting dose of the FSH gonadotropin, and what should be, if there is any added advantage of adding LH in this. Also, they include some cases like whether the embryo or oocyte accumulation is necessary.
So it's actually opened up a new style of ovarian stimulation. We are looking at other options like multiple cycles, cryopreservation of embryos, cryopreservation of eggs, duo-steam, and these are all new areas. Dr. Oendri, you talked about hyporesponders like others also did. How often do you see in your practice? And will you just explain to us what is a hyporesponder, what's a follicle output ratio or rate, and what's a FOI and all that, so that the audience is aware of these new terms largely?
Yeah, hyporesponder, as I already mentioned, citing an example also, hyporesponder can be either a young patient or an old patient. It can be a young patient with a good ovarian reserve or an old patient with a good ovarian reserve. At this point, we should be able to differentiate between a reserve and a response. These are patients with good reserve, but somehow due to some certain unexpected reasons, these patients have responded poorly to the conventional stimulation. So they are called hyporesponders. So hyporesponders, what happens is after giving the usual conventional stimulation, either we end up producing less follicles in them or we get less follicle oocyte output from them. There is something called a FOR, follicle oocyte ratio. That is out of a given number of follicles, how many oocytes we are finally retrieving. And ideally, that should be something more than or equal to 50%.
So that's excellent. Very nicely put. So what are the reasons for poor response of such category?
Yeah, it can be due to so many reasons. First, it can be probably the dose that I have started the patient on, probably what I am thinking as an adequate dose. Probably that has not been adequate for the patient. So probably I can think of increasing the dose in a subsequent cycle. Second is like we discussed about adding LH or substituting HMG. So probably this patient might do better with the addition of LH or HMG right from the stimulation day 1. Or probably it might be even so that we are probably dealing with something called the FSH or LH gene receptor gene mutation.
So we talked about that. Absolutely.
Yeah, these may be the probable causes of a patient hyporesponding.
Absolutely. So these are newer things, I would say, and these are opening up our vision to possibilities such as this. And based on that, a new paper has been published a couple of years back, which talks about first classifying the patients into group 1, 2, 3, 4 as far as the Poseidon criteria, and then suggesting the best practices for group 1, group 2, group 3, and group 4. I would request Dr. Shagurika to take us through what might be done in a group 1 or a group 2 poor responder, meaning somebody who had a good reserve, but she did not respond properly. We have done this in the previous discussion today, but if you can just highlight exactly how would you like to change things for a group 1 or a group 2 patient if she has had a unexpected poor response in a previous cycle.
So, first of all, it is very important, or I would say it is a privilege to get that patient back to you, because it makes a difference.
Absolutely. So transparency and
yeah,
proper
because
counseling is
if you
necessary.
have done the first cycle, you know what you have done, and then you can plan accordingly. Whereas if you get a patient who had a previous cycle somewhere else, it does make a little bit of difference, I would say.
Absolutely.
So,
these are valid points.
So if we get such a patient who who did not respond as we had expected, who had a poorer response, few things we may consider. First of all, we need to consider whether to change the type of gonadotropin, whether switching from FSH to HMG. Second,
so more
is
LH containing activity.
Yes. Secondly, whether to alter the dosage, like increase the dose slightly. I would say, as this slide says, that consider increasing the dose by 75 or 150 international units. And third, I would say, consider by all means adding recombinant LH to recombinant FSH from day one of stimulation.
Okay, so these are very valid points, and this is what the current practice and best practices that have been suggested are. We are doing this also in our practice. Dr. Oendri, for group 3 and group 4, while we know that they do not have too many eggs, so we cannot do much as far as the response is concerned, what extra can you do, like a duostim? Do you use it? Do you see any sense in using that? Or the triggering options, like they're available, dual trigger, double trigger? What's your experience? I don't want evidence. What's your experience of using all this, and does it make any difference?
Yeah, like I would say I've not used dual stimulation ever, but dual stimulation makes sense. I think the most important reason for doing a dual stimulation would be to probably give 2 cycles to a patient in a given time frame. That would be, I think, the most important benefit of doing a duostim or dual stimulation protocol. And regarding dual trigger is something which many of us use, and that is obviously to try to increase the number of mature eggs from the patient so that we get more embryos out of that particular patient. But definitely dual stimulation is something I've never used. I would say the restricting factor again is the cost factor, because doing 2 stimulations. But the good thing is being able to hold on to the patient. Like Dr. Sagarika said, once a patient hypo-responds or poorly responds, it is difficult to get that patient back for a second cycle with you. But if probably we are doing a dual stimulation with the patient, then probably in the same time frame the patient is doing 2 stimulation protocols, probably we can have more embryos to work with.
Can you just give us a sense of how the duostim works, like the logistics of a duostim cycle, please?
Yeah, it is like we start as usual, the usual stimulation protocol, starting from day 2 or day 3, do an antagonist cycle as usual, give an agonist trigger.
So we don't give HCG, we give an agonist trigger.
Agonist trigger.
Even though there is very little chance of hyperstimulation, we don't give HCG, we give agonist trigger.
Yeah. After giving an agonist trigger and doing the pickup, after pickup we give a gap of 5 days and again repeat the same stimulation. The idea of doing this is because now, after especially having done stimulations with cancer patients, what we have realized is that any cycle, it doesn't have only a single wave of stimulation, it has to be multiple waves.
Okay, so this is what the learning has been, and this is how we've applied this to our science. which is a very fair thing. I would like to just digress from the discussion that we are having. Has anybody amongst the panel used a progesterone molecule for controlling the LH surge instead of an agonist or an antagonist in a real world? Instead of the injection agonist or the injection antagonist, if you could substitute that with oral progestin, the patient would be much more happier. So is anybody amongst the panel used it or is planning to use it in future? Anybody can take that question.
Excuse me, sir.
Yeah, Dr. Nivedita.
Yeah, in Ranchi, we have used this medroxyprogesterone 10 milligram in a patient.
Excellent.
And we got the pregnancy, not in the first cycle, but in the second cycle, we got the pregnancy with this patient.
Okay, so then it can be done, and it can be done safely, and we can achieve pregnancies.
Yeah, to control the LH surge, it was used, and
this is something that we would like everyone to look at subsequently.
Just
right now, of course,
understand why would you use that, to reduce the cost, or what would it be?
Yeah, ma'am, that was just to reduce the cost. That was the reason.
Okay.
Cost could be one reason. Injections again, maybe that may be the another reason. We cannot use it in the same cycle because obviously progesterone damages the endometrium, and you cannot go ahead with the transfer in that cycle. But subsequently, again, I'm not a very big supporter of new changes, but this is something that I just wanted to check with the panel, and I do not have a yes or a no on this position. What about the triggering options? We have talked about HCG trigger, we have talked about agonist trigger, and we have all gravitated towards agonist trigger because of the lesser chance of hyperstimulation. I would like Dr. Pragya, she's keeping quiet, about what are the choices that she has in today's scenario, and when does she use what?
Actually, I decide the trigger according to the response of the patient of the ovarian stimulation. In case of higher responders, I always go for the agonist trigger. About
to be on the safe side.
Yes,
to be on the safe
side. Yes.
Absolutely.
In
so
normal
people with more than 12 oocytes, we should never look at HCG in today's scenario to avoid hyperstimulation, even more so in the COVID era, because we don't want any kind of a hyperstimulation happening in our patients. So that's a very clear message for normal responders.
In case of normal responders, I can go for agonist, I can go for HCG trigger if there is less number of follicles, like less than 10 follicles, and I am planning for the fresh embryo transfer, then I prefer HCG trigger, or we can go for the dual trigger in these patients also. And if there is a previous history of abnormal oocyte maturation in the previous cycles, then dual trigger are given, but at different time schedules. Like agonist trigger we give at 40 hours before the pickup, and the HCG trigger is given 34 hours before the OPU. And in poor responders
just
also,
a fun fact, doctor.
Yes.
Instead of calling this a dual trigger, they are calling it a double trigger. So they want us to be confused completely. The same molecules are being used, but when you use them together, you call it dual. When you use them separately, you call them double.
Double trigger.
The same thing. We should not get confused. And for poor responders, what's your choice? As Dr. Vendri said, do you use both the injections together or do you use them separately?
Together.
So that's again kind of non-controversial today. So addition of a GnRH agonist to HCG as a dual trigger is not recommended in standard patients, but can definitely be tried out in somewhat poor responders or somebody who had not had a predicted response the last time. Flexibility of timing. For a moment, Dr. Vendri had touched upon the cancer patients. Has she had patients where she had to start on a non-day 2 kind of a platform? Dr. Vendri?
Not really. I do not have experience with that. But definitely that is something that can always be done.
How would you like to stimulate somebody who comes to your clinic maybe on a day 9 or a day 10?
I think I would start off stimulation as usual.
Okay. You would like to pre-treat with antagonist, or you think you can start away right away?
I think I would be able to start away right away.
Okay. So that is taking away a lot of
experience with the MRKH patient. The intriguing thing about that patient is the patient never bleeds.
She doesn't have a day 1, day 2, right?
We can never do a baseline thing for her. We never know on which cycle day she's ever.
Correct.
I just had to start stimulation for her just like that, randomly.
Perfect. So Dr. Shagorika, did you have any experience of a random start protocol?
Yes, mainly for the fertility preservation care for pre-chemo patients.
Okay.
My experience, I always pre-treat them with antagonist and then do a start like gonadotropin stimulation.
Okay. And while literature says that maybe you'll get a couple of eggs lesser than a standard stimulation, do you think that it made a lot of a difference in your stimulation protocol, or you were happy with that?
I think, considering the profile of those patients,
It's mostly used for
yes,
oncofertility. Yes.
both, like, the patient was happy with really whatever we got.
Absolutely.
There was no much point in there was no scope of too much of fiddling around with because of the scarcity of time.
Absolutely. So random start controlled stimulation is probably as yet not yet recommended for the general population. I think this is very mature and a fair guidance. I like to pick on brains of everyone. What about that extra something that we all need to do to impress on the patient that we are the best for that patient if we are trying very hard for her? So do we use all these things that have been mentioned? What about testosterone? DHA is a favorite for all of us. Using a higher than standard dose. What's the take? Let's say I'll just choose a couple of them. What's the take on DHA supplementation and growth hormone supplementation to our patients who are not responding as well as we would want to? Dr. Nivedita, Dr. Shagurika, in that order, Dr. Vaindri, and then Dr. Pragya. Dr. Nivedita, have you used DHA?
Yes,
are you happy with it?
Yeah, in the patients who are having poor reserve, DHA I'm using, not growth hormones, because of the cost. Naturally, one is the factor. And DHA, well, no substantial difference can I see. I have not find that the AMH has shown an improvement or AFC has shown.
So you're mostly using because everyone else is also using.
That might be one of the reasons.
Okay, which is a very fair call. Again, Dr. Shagurika, what's any of the items that have been listed? Can you stick your neck out and say that no, I do this and I'm very happy with this?
No, see, in my because most of my experience is still NHS experience.
Absolutely.
We are very we have to be very cost effective. So there was no role of any adjuvant, like addition of anything, unless there was a clear-cut evidence, unless it was recommended by ESHRE or NICE or whatever. We did not use anything like that. However, if I go by literature, yes, growth hormone may have some role, but I am not very, what should I say? I do not use them so often.
It's again another fun fact that I'm sharing with my panel here in a lighter way, that while evidence is Europe based and they don't see much difference with any of these add-ons, I would say, by the time the evidence arrives in our country, the results become 10, 15, 20% better. So there's something in our mitti that makes all these interventions and adjuvants do extra bit. Dr. Vaindri, your comments, please.
The only thing I would probably go with is a day 2 or 3 embryo transfer instead of waiting for a blastocyst. That's all.
Okay, that's also a very nice way of looking things. Yes, that's primarily to avoid.
I think the only reason of using that would be to probably convince the patient that
absolutely
medicines are not going to work.
Absolutely, that's fair. Dr. Pragya, your comments, please. Dr. Pragya, your mic is switched off, please. I'd request the panelists to keep the mic switched on because we'll be very quickly moving into the rapid fire section.
Yes. I have not used as much of adjuvants, but surely I have used DHEA supplementation for some poor ovarian reserve patients.
And what's your experience, please? For the benefit of my audience, we would like to know whether DHEA actually works for our patients.
No, more or less same. Nothing significant.
So that's something that it's a takeaway for all of us, that while we add the add-ons because we want the patient to be happy, it may not really make any difference to them. We have done the duo-stim, so we will skip these slides. Fertility preservation is the domain of the expert. Any of you, and I would like to point it out to my audience also, fertility preservation for social egg freezing is something that's hyped up. It's not so much in our practice as yet, but fertility preservation for oncofertility is something that we should seriously look at. And that's possible in today's scenario because so many women are surviving cancer and coming back to become pregnant and mothers. So that's something that we should keep in mind whenever and wherever we see patients who are suffering from cancer and would like to preserve their fertility. OHSS. This couple of points on this, everyone, in this COVID scenario where we are afraid to start cycles because of the increased risk of thromboembolic events. OHS has become a bigger specter, a bigger risk also. So what are the points that are in your mind? One is agonist trigger that has been pointed out by all of you. Anything else, 1 point each from all of the panelists, which will make sure that the patient would not go into hyperstimulation at all. Dr. Nivedita, what is your first, other than the agonist trigger, what is it that you ensure that she will not go into hyperstimulation?
Apart from the agonist trigger, for the OHS it's very important to have a follicle that my base starting dose of gonadotropin should be such that the patient.
So your starting dose is low. Dr. Shagorika?
Patient selection.
So she will select her patients wisely and only stimulate women who have no risk of going into hyperstimulation. Dr. Vendri?
Yeah, close monitoring of the cycle, obviously, because whenever we feel that probably the number of follicles are increasing, we might choose to lower the dose, taper the dose.
Okay, so for hyperstimulation is the end product. We have enough advance notice for that. If we detect hyperstimulation to be coming our way, then we can lower our dose. Fair call. Dr. Pragya?
Yeah, I will always go for the free all policy.
That's very important. If we do not transfer in that cycle, the risk of the secondary hyperstimulation is much lesser. So thank you, panel. These very important points for hyperstimulation. Again, for luteal support, one by one. Is it oral? Is it vaginal? Is it injectable? Is it sublingual? Is it subcutaneous? What is it and when is it? Dr. Nivedita?
So it is gel, generally gel, as well as Dufastin, that is the oral dihydrogesterone.
So your is 2, oral and gel. Once daily, twice daily, thrice daily?
Gel is, that dihydrogesterone is twice daily and gel is also twice daily.
Okay. Until
the patient till the HCG report, we get that.
After she is pregnant, do you stop or do you continue?
No, sir, we continue till the placenta, 12 weeks at least, till the placenta is fine.
The placenta takes over. Dr. Shagorika?
Vaginal progesterone, for micronized vaginal progesterone, 400 BD, up till outcome, and then if she is positive, then carry on up to 12 weeks.
Perfect. Dr. Vendri, what's your choice?
Yeah, actually all are equivalent basically, but I usually prefer gel, and it is a little illogical even though I usually administer gel twice a day, and Dufastin for the additional benefit of immunomodulation. So I would usually continue both Dufastin and gel up till at least 12 weeks of pregnancy, though that is also a bit irrational, but to be on the safe side, I would do that.
There's so many irrational things that we do, but this is a real time panel discussion and not a copybook panel discussion. Dr. Pragya?
I go for Dufastin, 10 milligram 3 times a day, and along with the vaginal micronized progesterone, 200 milligram thrice a day, 3 times a day.
So the house is pretty much confirmed that they'll prefer either a vaginal or a gel, but they do not use injectable because of the pain and the other issues with the injectable. And everyone wants to add on a dihydrogesterone because of the possible immunomodulatory effect, except for Dr. Shagorika. I think these are fair and non-controversial areas. I would like to talk about a few things here. There's something called time to pregnancy. And this is something that we have to keep in mind when we counsel our patients. So time to pregnancy is also an important consideration in these days while choosing the right protocol for her. And even with timing of pregnancy, it seems that the antagonist protocol is better than the agonist protocol, because usually the time to pregnancy is a month and a half lesser with the antagonist protocol compared to the agonist protocol. We would also like to mention here that assisted reproduction and thromboembolic events in this days of COVID-19 pandemic is a reality that we have to be conscious about and be very sure that we do not overstimulate our patients, do not raise her estradiol levels to the extent that she may be prone to thromboembolic events. I would now come to the last section of our discussion, that is the panel discussion, rapid fire questions, which have come in from the audience. A very nice interactive audience has bombarded us with questions, and I'll set the rules very clear. The questions will flow from Dr. Nivedita to Dr. Shagorika to Dr. Vendri to Dr. Pragya in that order. So the question number 1, I have gone through one cycle of egg stimulation in IVF. I had 14 eggs retrieved. Out of them, 12 were fertilized, but we got only one day 5 blast and 2 day 6 blast. That means total of 3 blast. 2 day 6 blasts were transferred. I got pregnant with one, suffered miscarriage at 9th week with detection of heartbeat. Now I'm left with only 1 day 5 blast. So what may be the possible cause that I have only 3 blastocysts out of 12 eggs that we started off with? And I will be obliged if you answer my question, because I am very worried about my second embryo transfer with only 1 day 5 blast. Dr. Nivedita, how would you counsel this lady?
Day 3 blast shows a good stimulation. The cycle was good and you have a good embryos that grew to the blast stage. So I can say that the stimulation, everything was quite good, because to get 3 blasts from 12 embryos is, I think it's a good ratio to go forward.
So Madam Payal Chaudhary, the answer to you is actually 3 blastocysts out of 12 oocytes is not a bad number.
Yeah.
It's a fair number, and there's a fair chance that one of these 3 blastocysts is a healthy blastocyst and shall be able to give you an ongoing pregnancy. Wish you all the best with your future transfer. Next question to Dr. Shagorika. In patients with PCO with irregular cycle, when can we start ovulation induction? After drug withdrawal, menstruation, or any time of the amenorrhea period? Question comes from Dr. Mala Banik.
Ovulation induction means
most probably for natural conception.
For natural conception, okay. For PCO patients with irregular cycles, I prefer a withdrawal bleed, like an induced bleed, and then start the ovulation induction.
Okay.
Process.
So you would like to establish a day 2 and then go ahead.
Yes.
Okay, that's more for the convenience of the doctor and the patient together. Dr. Oendri, your question: how much gonadotropin use is safe in this COVID period? This question comes from Dr. Motwani Nand Kumar.
See, there is nothing like that. It cannot be said just like that. It depends on the patient you are stimulating, whether an expected normal responder or a poor responder, or probably a hyper responder. And as has already been discussed, for a poor responder, the maximal we will go up to is 300 units, not more than that. For a hyper responder, the minimum dose even then should be probably around not less than 150. And for a normal responder, it would be something between 150 to 225.
So you would advise caution basically in these days, so as to not to go overboard, but to be rather be standardized with a 13-14 oocyte kind of a response. Is that what you're saying?
Yeah, very true.
Okay, fair enough. I hope that satisfies your question. Dr. Pragya, the question to you is it better to go for a standardized protocol or an individualized protocol for your patients?
I always go for the individualized protocol.
So Dr. Pragya feels that an individualization of protocol gives a better
It's much
outcome.
better, yeah.
Okay. The next question goes to Dr. Nivedita. How do you do testing for polymorphism, and how do you manage if you suspect polymorphism?
Yeah, testing for polymorphism is right now not available. We are not doing it any routinely. And
so that's something that you can clinically suspect.
Yeah, we can suspect depending, that is retrospective diagnosis. And if we suspect this and the patient falls in Vascular group 1 or 2, one of the option is to increase the dose of FSH by 50 or 75 international unit. Secondly, we can go to the agonist protocol or add LH. And then with the trigger also, dual trigger can use. These are the methods, these are the options we have.
Okay, so fair enough.
By increasing the dose to cover the receptor sensitivity.
Next question goes to Dr. Shagorika, comes from Dr. Chinwe Iguila. If a patient was diagnosed poor responder, would you add LH from the very beginning?
Not always, no. If she's an expected poor responder, you would personally plan her gonadotrophins accordingly, but not necessarily adding recombinant LH per se from day one.
He has a follow-up question. Do you wait for the cycle to fail before you adding LH?
It is a difficult decision to add a recombinant LH from the start. So yes, we need to give it a try with the more conventional approaches in our first cycle to see actually how she responds. And then if it fails, then yes, it is unfortunate, but it was possibly one of the, and that in that part, counseling plays a very important role. Explaining to the
other
patient.
reasons for failure as well.
Yes.
However, if you feel that stimulation was one of the causes, then you would like to change by adding LH.
Yes, in the next cycle.
In the next cycle, okay. Dr. Vendri, your question again from the same gentleman. Why have you discarded doing day 2 FSH? What wrong did day 2 FSH did that you stopped you doing day 2 FSH?
No, it is not about discarding. See, like we already discussed, antral follicle count and AMH are definitely much more sensitive. So instead of doing day 2 FSH, it is better to go with something which is more sensitive.
Okay, and he has a add-on question to this. How many of your antagonist cycles, percentage-wise, are you routinely freezing? And is it true that agonist trigger is not good for endometrial phase for supporting a pregnancy in that cycle?
Yeah, see, whether or not we freeze or whether we transfer in the same cycle, that will basically depend on the number of follicles we produce out of that patient in a particular cycle. If we see that the patient is hyper responding, so obviously we would choose to freeze in that particular cycle. But if we see that the patient is a normal responder or a poor responder, then we can go ahead with transfer in the fresh cycle also. And regarding what was the other question?
So the agonist in the agonist trigger cycle and antagonist cycle, do you think the endometrial receptivity is compromised?
Yeah, definitely. After giving agonist trigger, if we are not giving a dual trigger, giving only an agonist trigger, there is always a chance of luteolysis. And typically, we will observe that patients who have been given only an agonist trigger, typically following pickup, they would bleed within the next 7 days. So definitely, after giving an agonist trigger, it is never recommended to do a transfer in the same cycle.
Okay. Dr. Pragya, thank you, Dr. Vendri, for your response. Dr. Pragya, this question comes from Dr. Chandrasekhar Singh. What is the difference between a fresh and a frozen transfer, and what do you prefer and why?
Fresh embryo transfer means when we are creating the embryo in the same stimulated cycles, we transfer the to the uterus. Then it is called fresh embryo transfer. If we are planning to freeze the embryos and then we transfer in the subsequent cycles, then it is called frozen embryo transfer. I actually prefer frozen embryo transfer because in the stimulated cycles, there are the supraphysiological levels of estradiol, the endometrial receptivity is not so good. So I mainly go for the frozen transfer.
So you feel that frozen transfers actually give you better results, and with a good lab and freezing of oocytes being done these days and by vitrification method, the results are definitely better. Dr. Yamini has this question. Dr. Yamini Agarwal from Shiliguri, she has this question, and I'll use this question to come back to Dr. Nivedita. Is what is your experience of using HMG versus FSH in a hyper responder or in a PCO patient?
In PCO, FSH offers works better than HMG. That is my personal experience.
Okay, so she feels very clearly that an FSH is more predictable and better to work with in a PCO patient. Dr. Mukesh Fugla from Dibrugarh has a comment, and we thank you for your participation, is that I've used OCP for down regulation in a large number of donors, and chances of premature ovulation is slightly increased. That's what he says. There is another comment by Dr. Gaur Kishore Chakravarti. He says, a useful and worthy and a pragmatic discussion. I must thank all my panelists for such good comments. I have stimulated many donors in the luteal phase with very good success. Donors are good candidates for these kind of experiments. This is again Dr. Fugla continuing. Dr. Shagorika, this is a question for you. Do you see any role for follicular flushing, especially in poor responders? This question comes from Dr. Gayatri.
The evidence more suggests that there is possibly no role of flushing really, but practically, I mean in practical purposes, if we are seeing that really we are not getting any oocytes, my general instinct is to flush at least until I get 3 or 4 oocytes.
Okay, so that's something again a go-to instinct. If you're not getting oocytes, maybe something is wrong, and then we flush. Dr. Gayatri has this question again. Is there any possibility of OHSS in an agonist triggered cycle? There are papers to that effect. Dr. Vendri, what's your comment on this?
See, very less actually. In fact, I'm wondering why there should be a chance of OHSS in an agonist triggered cycle, endocrinologically speaking, but I don't think.
Okay, so there are 4-5 papers on this, and out of them 2 or 3 have been withdrawn because they found incidental HCG in the system. Maybe someone was carrying an ectopic, somebody had by mistake taken an HCG trigger. So what Dr. Indri is saying, logic says that should not be any chance of hyperstimulation, but then that's the human body and there could be idiosyncratic responses. Dr. Yamini Agarwal's question, can we lower the dose in the day of starting antagonist if we see hyper response? Dr. Pragya, would you like to take that question? Would you like to lower the FSH dose on the day of starting the antagonist?
If you... I have never done this.
Okay. Anybody in the panel want to take this question? Dr. Shagorika, Dr. Indri, Dr. Nivedita?
Yeah, I would just like to add that on the contrary, when the antagonist initially started, I remember when we were doing our FNB between 2007 to 2009, that was when the antagonist first came. There was an idea of, in fact, increasing the gonadotropin dose after adding the antagonist, not diminishing. But so afterwards, it has been seen that there is no role of even that.
Okay, so that it makes no difference if we lower the dose, but that's not something that we routinely practice as yet, right?
Actually, it is now recommended that it is better not to alter the dosage during the stimulation cycle.
Okay, and it's a good practice not to alter the dosage during the stimulation cycle. Okay, Dr. Gayatri's comment, Dr. Professor Fatma Ashraf has good things to say about our panel. Thanks to Nova Fertility for creating such scope for us. Dr. Chinwe from Nigeria, another question from him. What do you mean by the window of implantation? Who will take this question? Dr. Nivedita, what is it?
Window of implantation is the time period when the endometrium.
Yes, please.
Yeah, actually my video has gone, sir. A window of implantation is basically the time period when the endometrium is receptive to the embryo. That is the time when embryo can implant in the uterus, that is endometrium, and best chances of getting pregnant.
Okay, so that's usually 9 days post oocyte retrieval. That's what people say. Dr. Sri Mangal Nivas Chandropal, he says it's a good discussion. Dr. Poonam Lal from Patna, thank you, madam, for tuning in. Excellent panel. Congratulations to all the panelists. Another doctor from Nigeria, I do not support double stimulation in donors because it is extortion. So we are not doing it for donors. We are only doing it for poor responders to increase the number of eggs to be yielded in a short time. I think
and
that
sometimes in cancer patients.
And sometimes in cancer patients for a similar reason. I think I would like to take the final words as the moderator of the panel. So for all of you who are listening in, and thank you for participating so extensively today, choose your protocols wisely and stick to them. Learn these protocols, learn the nuances of these protocols, and do not change these protocols very often. Keep reviewing literature, but change only occasionally when there is a compelling reason for you to change yourself. Time to birth, as to lower the time to birth, should be the most important guiding principle when you choose the stimulation protocol. As in the past, I again thank my panelists, Dr. Nivedita, Dr. Shagorika, Dr. Indri, Dr. Pragya. You've been wonderful. You've taken the questions very nicely. You've sorted out a lot of issues here. I thank you all, my panelists, and I thank you, audience, for your kind attention. We meet again next Saturday for the final episode of this series where we talk about the infertile male. Thank you again.
Thank you, sir.
Thank you so much.